your thoughts are, you have to just say this is axial non-contrast CT head. So who's going first between you guys?
Ma'am, I'll start. Rushabh.
Rishabh, okay, great. So as I'm scrolling through, is anything catching your eye? Like, is it at a first glance, do you see any hemorrhage, edema, mass effect?
So there is no mass effect. The midline structures are not displaced.
Mm-hmm.
Uh, there are no intracranial hemorrhage or any hemorrhagic foci in the brain. There is no intraaxial hemorrhage per se.
Okay. What structure is this
Uh,
anatomically?
Internal cerebral vein, ma'am.
Uh-huh. Yeah, so where the confluence is and straight sinus. Okay, good. Do you think they are a bit dense or?
Yes, ma'am. They are appearing hyperdense, ma'am.
Mm-hmm. And what about the thalamine? What about the white matter? If you look at the deep white matter,
The white matter is hypodense, ma'am.
okay, so is that normal or abnormal?
The contrast between the gray white matter it's increased, ma'am.
Okay, so like, will you call it edema or will you just let it go?
Ma'am, to call it edema, the Gyra and Sulcar still maintains,
Mm-hmm.
not it.
Okay, okay. So like, you don't think that this is edema because the guidance will maintain? Okay, that's fine. And but can you have just abnormal patchy hypodensity in the white matter?
Mm, yes, ma'am.
Okay, but we'll come back to this. Okay, and what about the cortex and the extraxial spaces? Do you think this is okay, or is there some collection here? Because there is more space here, right? As compared to there's less space.
Is uh, subdural spaces appear to be accentuated, ma'am.
Okay, so does it mean anything? Will you put it in the impression, or will you let it go?
Mm. Can we write as benign enlargement of subdural space, Bessie?
Bessie, benign enlargement. Yeah, it's not. Yeah, it is a good term to think about, and definitely you can entertain that. But this is yeah, this is like I will like it is along the spectrum of Bessie, but I'll probably just let it go. It is very minimal, right? Sometimes the presentation of Bessie is more like benign kids where there is rapid expansion of head circumference. It is more around the 3 month to 6 month mark rather than early on in the first month of life. So yes, they're definitely, they look a bit prominent, but they're just totally normal for this age. I mean, Bessie is also a normal variant, but this is some like a precursor or like form first of that, if you know what I mean. Okay, so so far we were debating about this high density. So how do we dissect it? Is this normal or abnormal? What, and people can type in the chat, and I see a first response by Reena, and you can maybe help Rushabh or you can confuse Rushabh by typing in your responses, and maybe then Rushabh and Joey, it will be your discretion to use help from the audience, whether that help is useful or distracting to you. So let's see if we have more comments in the chat. What do people think about this high density in the venous sense?
Right.
Dr. Keder Keder has mentioned dural sinus thrombosis. CVT is the same, right?
Yes, ma'am.
Cerebral venous sinus thrombosis. Okay. What else? Arisha has written normal. Okay. So let's see. Slow flow, anemia. Okay. So we are debating whether this high density in the venous sinus, is this normal or is this thrombosis? Do we need a venogram? Do we need an MRI? Um, and this is the fontanelle, right? It's a newborn, close to like 1 month age. high hematocrit, dehydration, normal, CVT causing white matter edema. So there are very conflicting answers here, right? So how do you decide? Vikas has written straight sinus, sagittal thrombosis, and venous infarct, right? Because of this hyperdensity which we see in the white matter. So how do you put these things together? And the history was subconjunctival hemorrhage. I don't know about any congenital heart disease, so no, no, no history of congenital heart disease to answer that question in the chat. So you have lots of options to choose from, Rishabh. So, and which way do you want to go, and how do you want to, what do you want to do next?
To do CT venography to rule out dural sinus thrombosis.
Okay, so you're worried. Okay. Mhm. So, yeah, so I won't take too much time on a single case, but the main reason I got this image here was to just familiarize you with the spectrum of what normal can look like in newborns, right? So I think we have some good answers here where people have mentioned high hematocrit and also dehydration to some extent, right? So the answer is correct. So Divya and who else? Irisha, you guys, whoever said normal or whoever thought it was normal, you guys are right. So a little bit of high density in the venous sinuses in newborns and up to especially like in the first month of life in neonates is completely normal. And it takes time, right? It takes time to get comfortable calling this normal and not to proceed with actually doing a venogram or an MRI. Um, so how do you distinguish whether this is can anybody tell in the chat? Somebody has written, Irisha has written no expansion, but I mean you can have thrombus without um, expansion also to some extent. So how do you differentiate whether this is just normal high density of a newborn versus something else brewing? Do you have any thoughts, Rishabh? How do we practice calling this normal in a newborn? Hmm. Compare material attenuations. Okay, that's fine. Yes, you can put ROIs and see whether how high it is. And yes, arterial. That's also that Ashwini has mentioned. That's really important. So sometimes when you have overall high hematocrit or dehydration leading to just apparent high density of the sinuses, it can be a good idea to look at the arterial side. This is not exactly showing up nicely on this image, but for example, like the basilar artery density, and let's say one of the MCAs, sometimes it can be useful if they are also comparatively higher. Yoshi, you have mentioned follow-up scan and clinical correlation. I will probably not choose that, unfortunately, because we are the one who should be doing the correlation, right? So we have the charts, we will have the history, and if you're worried about anything, sorry, if you're worried about anything in the clinical history, we should be correlating. So if there is one take home message from today, please do not write the word advice clinical correlation. Follow up is fine. Yes, occasionally we need to definitely follow up a few things to figure out whether something is transient or not. But clinical correlation is a sentence or a phrase which I will never ever put in my report. So what else do you do when you want to write clinical correlation? You can look up the charts and say that, hey, if there is fever or if there is so and so, if there is so and so clinical symptom, this can be a consideration. So you can use clinical history in a way to help you with your differential rather than just saying like a laundry list of differential. You're giving like 5 entities. This could be normal, this could be slow flow, but I can't exclude thrombosis. Let's go, please correlate clinically and hand it back the report. No, that is not the way we will be doing. So, first case, first patient, our take home message is there are multiple take home messages here. Number one is when you go back to your hospital, to when you have your access to your PACS workstation, I want all of you, especially residents and trainees, to get comfortable looking at several, if not tons, like at least five, or open at least 5 or 10 CT heads, non-contrast of, you can sort by age. In most packs, you can just do date of birth and open scans of young kids, especially less than 6 months, less than 5 months, especially newborns, and look at the white matter. So the second question was somebody is worried about, obviously, venous infarcts, right? So this hypodensity. So Rishabh, can you tell me how can you have normally low density in a newborn in the white matter? What could be the reason?
Uh, Myelination is not complete, ma'am.
Exactly, right? And what does it mean if myelination is not complete? What
There
what is
more
the
water content
Mhm.
than
More water? Exactly. So myelin is mostly fat, lipids, and this is more watery. So the newborn brain is so watery. So that is why we get low density. And this can be sometimes exaggerated depending on what kind of scanner you have, what parameters, low dose CT. So it takes time to get comfortable with your own scanner. So, number one take home message, do not use the word clinical correlation. We use clinical history and ask specific questions. Second, the next time you have packs in front of you and you have time, spend 30 minutes looking at um, multiple, if not at least 5 or 10 studies. Just open randomly, okay? Don't even look at the clinical history. Arrange them by date of birth and get comfortable by what is the normal range of density of the venous sinus, what is the normal range of low density in the white matter, can ventricles be small or big, and how wide extraction spaces can be. And do you think there could be some cortical anomaly here? Like if we were to do MRI, like do you think this could be a little bit smooth or something to do with the cortex here?
no, ma'am. The frontal lobe gyri looks normal to me.
Yeah. So again, it can be a bit overcalling, right? On CT, it can be just too much. So we are not assessing for cortical malformations unless it is like very obvious lissencephaly or diffuse polymicrogyria. It will be very hard. So this is totally fine. It's just because of the extraction spaces. And then you can do different window, look at the normal sutures and fontanelles, right? So our first case is a normal CT head of a newborn. And I think, yeah, bone window I'll probably skip for now because my system might crash. It's lots of images. Do you have any questions? Somebody has written myelin fat. It should be more dark than non-myelination. Yeah, so that's the thing. So uh, water, if you look at the Hounsfield units, this will be different from the MR signal, right? So you can just look up the different Hounsfield units, and water is low density. All right.
If there is dehydration and raised hematocrit,
Yeah.
wouldn't we
Yes, yes.
expect in all sinuses wipe properly straight or the delta sign which we see?
Yeah, that's right. So I think all the sinuses are affected, right? So even if you window it properly, windowing is very helpful. So if you look at the superior sagittal sinus here, even that is relatively high. So this is a uniform occurring, whether it is high hematocrit or due to dehydration or polycythemia due to young age. So this will be a uniform feature, generally speaking, right? What was the cause of conjunctival hemorrhage? I don't know, and I don't have the charts open. That's a good question, but I don't have like the clinical charts open, and I don't remember. I can bring that next time, okay? But that's not relevant. Our answer from our side, it was normal, and I don't see any follow-up imaging. So that means the child was definitely clinically well, and there was no MRI or CT performed later. All right. Final diagnosis, yeah, just nothing. This was normal. This our scan report was normal, and there was no further follow-up done. The child was fine. Okay. Let us see another one. All right. So this is 4 day old. So this is even younger child. And is it again you, Rishabh, or Julie? You want to just practice speaking?
Yes, ma'am, I'll answer.
Okay. So let's look at this together. So this is a even younger child. So they are only 4 days, and let yeah, lethargic, and there is clinical history, obviously, but I'll just explain later. This is more obvious than the first one. So how do you describe this?
Ma'am, there is diffuse hypodensity involving the white matter of both the cerebral hemispheres and
Mhm.
the cerebral hemispheres.
Mhm. Right.
Uh,
So diffuse hypodensity, meaning what is your diagnosis then?
diffuse, ma'am, hypoxic injury.
Yeah, hypoxic injury, right? Yes. And what is this high density due to? So again, where what is the location of this high
Venous
density?
sinus, superior sagittal
Venous
sinus.
sinus. And what else other than the sinus? What runs through the midline here? Is it only in the sinuses
Parks.
or? Yeah. So the interhemispheric fissure, right? So it is not, this high density is not exactly all within the venous sinus. There is also some high density along the interhemispheric fissure. And you can see the fontanelle is bulging, right? And all the sulci, they're all effaced. So this is global edema and white matter injury. There is some sparing of the deep structures, but they're also otherwise swollen. So how do you describe this? Oh yeah, like, is this hemorrhage? What is this?
Yes,
This high
ma'am. It's
density?
linear hyperdensity along the falx and few curvilinear
Uh-huh.
hyperdensities along the sulcal spaces in the parietal and occipital, parietal and occipital lobes.
Uh-huh. Okay. So if I tell you this is not hemorrhage, what else can explain this high density?
Venous congestion, ma'am.
Okay. And any other better descriptor? Because you're seeing so much of global edema, right? In the chat. Severely chai, congestion, white. Yes. So the cello. Yes, I see that pseudo subarachnoid word. Have you heard of this pseudo subarachnoid
No, ma'am.
term?
I'm hearing it for the first time.
Okay. So, when you have diffuse edema in the brain, um, the dural structures, the interhemispheric fissure and all, they have this relative high density because they are like standing out against the overall edema of the brain. So it is looking as if there is some linear high density and hemorrhage, but in fact, this is pseudo subarachnoid sign because of the apparent low density of the adjacent structures. Does that make sense?
Yes, ma'am.
Okay. So just remember this term pseudo subarachnoid sign. So whenever you have global edema, it's similar to the white cerebellar sign. Uh, that there is relatively, it's the cerebellum is not exactly white, but it is just standing out right against the global edema. So in a similar fashion, the dura, the interhemispheric fissure, they will stand out as high density structures, which will mimic blood, but it is not blood.
Yes,
Okay.
ma'am.
Okay, so this one is more florid, very unfortunate. Obviously, their prognosis was dismal, and this patient, like, they had to withdraw care. They were not even able to do any follow-up MRI. So this is an extreme example of what severe hypoxic brain injury can look like in a newborn. Um, and again, we see similar features of some uh, high density along the venous sinus and white cerebellar sign. Um, Sometimes you get effacement of the cisterns, but here there is no coning. And I think somebody had written mega cisterna magna, right? What do you think about this area? What is this structure anatomically?
Vermis.
Vermis, perfect. So somebody has written Vermian hypoplasia. So do you think this is Vermian hypoplasia?
No, ma'am. The cisterna magna is prominent, but the
Mm-hmm. The
vermis looks normal.
yeah,
We'll have to check later.
yeah, the sagittal, perfect. Yeah, so the vermis extends from the tectal plate roughly to the like the lower medulla, and this is a newborn, right? So in newborn sometimes you can get a little bit of prominent retrocerebellar space, right? So that's totally fine. So anyway, CTs we are not using it for anatomical detail, but sometimes it's not a good idea to overcall stuff here. And I will not mention cisterna magna or anything in the impression because it's not, number one, it's not relevant, and uh, I would just simply use the term prominent retrocerebellar CSF space. Okay. And do you have any questions for this particular case?
No, ma'am.
All right. So we saw first normal CT head of 1 month old. We saw one extreme example. The good thing is, like, on CT, we are not usually asked to detect subtle HIE or mild HIE, right? That is not the role of CT. So the role of CT in this case was to figure out extensive damage and midline shifts and mass effects and hemorrhages and big areas of edema, right? And this is what we are good at. So we were able to tell them, hey, the prognosis is bad. If the clinical features are like they're terrible, and they have to like make a decision of withdrawing support, they can potentially have to do something like that. They can do. So that is the role of CT in this scenario. Um, we will obviously be doing MRI, right? So if we have to pick up early HIE, if this is like pre-cooling or post-cooling scans, right? So we will see some examples of those also. But first, I'll just show maybe one or two more CT scans. So this is the next one is slightly older kid. Not the chat window. So back to you, Rishabh.
Yes, ma'am.
Okay.
Ma'am, there is a crescentic hypodensity along the right cerebral convexity.
Okay.
Could be subacute or chronic SDH. The gyran sulci appear, they are effaced. So some cerebral edema component can be there. There is midline shift also.
Right. Ventricles,
Ventricles are effaced, ma'am.
they're effaced and they're deviated towards the left.
Lateral side.
Mhm. Anything happening at this level?
Cisterns are effaced.
Hmm. So which structure is this? Which system?
Uh, that is ma'am, prepontine cistern.
Yeah, so prepontine and in front of the midbrain, perimesencephalic, right, suprasellar. So we are looking for any early uncal herniation, right? Looking for deviation of the uncus. So there's definitely some crowding, some early crowding where the uncus is medialized. There's usually, whenever you're reading any acute CT head studies, especially when you're to check for any cerebral edema, look at this slice just near the midbrain. Look for any look for CSF spaces. Make sure there's enough space. So what else is going on and what do you want to do next? So you said there is, let's go back to the this collection again, right? So how will you describe it?
Concentric concave convex hypodensity along frontal and parietal lobe, right of the right frontal and parietal lobe.
Hmm.
Uh,
So it's almost hollow hemispheric, right? So it's like almost the right entire hemisphere. Its volume will be so big, right? Because if you look at the if you go from top to bottom, it's covering the nearly the entire surface. So what could be the etiology?
Traumatic SDH.
Traumatic SDH. Okay. Anything which goes against trauma?
There are no bony fractures.
Yeah, there were no fractures. Okay, what else?
Mm.
What
Acute,
else?
it's not acute. Acute would be hyperdense.
Okay, there will be lots of things to talk about. Not okay. No, you're saying it's not acute because it's not hyper dense. Okay, I'm just writing this down because we'll come back to this statement again. Okay, what else do you think? So you're saying it's probably not traumatic because you don't see too much high density, you don't see a fracture. Anything else, like anything related to the mass effect? Like can when you have a traumatic SDH, can it cause
Effect
this
is
much mass effect?
Mass effect is more than the size of SD.
Hmm. Yeah. So the mass effect is maybe a little bit more disproportionate. It's a bit more than expected, right? So let's keep that in mind. So people have written battered baby, blunt trauma. No, somebody has written no contusion, NAI, iPhone. Who's this iPhone who's written empire? Probably, are you saying empire? We'll come back to this. No scalp hematoma, right? So if you're saying there is trauma, there are no external signs, right? There is no uh, subgaleal injury, there is no fracture, right? And there are no other signs. So instead of calling this hemorrhage, can it be something else? What else can it be?
Subdural effusion.
Okay, so okay, how do you describe effusion? Like, what is it exactly? What can be the etiology of subdural effusion collection? Hygroma. There are lots of choices to choose from. Some are good choices, so some are confusing. So you have to pick who's actually helping you, Rochelle. Somebody, will you do contrast, CSF collection due to dural tear, infection, meningitis, hygroma? Okay, have you heard these terms? Have you heard subdural hygroma, subdural effusion, collection? Do you have any understanding how we distinguish them?
Subdural hygroma will be of having similar attenuation as of CSF, ma'am.
Okay.
Uh, and effusion or collection will have more attenuation, but less.
Could be more.
uh,
Hmm. And in terms of etiology, is there any difference?
Subdural
Okay.
can be
Mm-hmm.
chronic sequelae to chronic long-standing SDH.
Okay. All right. Okay. So finally, somebody has asked a right question. I don't know who the iPad is, but you can rename, ma'am. What is the clinical history? Okay. So I started this case, and then before I could say the history, we started the imaging findings. So I did not reveal the history, right? So and history can sometimes be misleading, right? So what if I tell you that this scan was obtained after the child fell, like he just fell from a height or whatever ground? So then your history is like trauma, right? But maybe he fell because he had some sort of like neurological deficit, or something else going on, which and the fall was secondary. So the real history for this one is fever, headache and lethargy, and rule out cerebral edema or thrombosis. That's the history. Fever, headache, and lethargy. So now, how do you think that you will describe this collection?
Meningitis or related subdural pus collection or empyema.
So meningitis is technically in the leptomeningeal spaces, but when you have a collection which is confined to the subdural space, you will call it a, yeah, in subdural empyema, right? And yeah, that is also right. You can have a sterile effusion secondary to meningitis, and it can be hard to tell on CT alone whether this is sterile, whether this is infected. But you look at the degree of the mass effect, right? So such a bland collection will not be able to ignite such massive effacement and mass effect. Um, you know, so that's the number one clue. So the number one take home from this particular case is that sometimes history can be misleading. This child can very well present with a fall, and we will be tempted to say that, hey, there is just a bleed, there is maybe some mixed density hemorrhage, and it is causing mass effect. But then sometimes we have to pause and say, oh, you know what, this mass effect is just way too much for this collection. So what if this extraxial, the subdural stuff is maybe infected, or there is some empyema brewing here? Now that Dr. Chirag has mentioned age influenza, that I will probably not put in my report. That is not our job. Yes, there are certain patterns which are described, and certain bacteria are more common than others. But um, anyways, okay. Yes, can we check middle ear? Definitely. So we will have to follow our checklist on our CT scan. So we are not done yet. Okay, you have raised a very good possibility that this could be an empyema, but there is a lot going on. Is there anything else happening in this image other than the ventricles, other than the collection? Do you see any other abnormality? Carmen has mentioned, but no, that is a bit relevant. Same, some iso to hyperdensity in collection. No. So I was trying to point to multiple other findings. So what do you think is this?
There is a hypodensity in the right parafalcine region along the frontal lobe, ma'am.
Yeah, so what is that?
No clue, ma'am.
So, this is, if you describe the location, this is parafalcine, right? So this is against the fog. So this is outside the brain, outside the parenchyma, and it is very similar density and similar sort of extraxial location. So this is just another site of empyema.
Okay.
Okay. So this is just another pocket of pus here. And just close to it, what structure lies? Um, this thing here. What is this? If we're just talking about these structures, what is this triangle here?
Yes.
That's the superior sagittal sinus, okay? That triangle. Julie, you have asked a very good question in chat, so we'll come back to it, okay? So there is this little triangle of high density, which is the location of the superior sagittal sinus. And if a child has clear clinical presentation of infection, fever, headache, lethargy, and you see such a big collection, definitely the next step is to do a contrast enhanced venogram or a contrast study to look for any filling defects in the venous sinuses. And that was done. So let's see. So you can see the collection. Is it enhancing or not?
Non-enhancing, ma'am.
Yeah, but it doesn't exclude, right? So lack of enhancement will probably not will not exclude the, hey, this is not, there's no peripheral enhancement, so I won't call it infection. That is not true. So answer, um, it has, there are multiple other features also, right? So now we are doing contrast to look for maybe some other pockets of pus. So this is that empyema along the interhemispheric region, and then we will be using our contrast sequence to look for any filling defect in the venous sinuses. And they can be hard, right? Sometimes, because what are the normal variants you can see in the venous sinuses, which can present as filling defects?
Arachnoid granule.
Right, yeah, some people had written, right? So do you have in your mind, how do you distinguish arachnoid granulation from a clot? How do you do that?
The arachnoid granulations like peripherally based and they project into the sinus, ma'am.
Mm-hmm. Mm-hmm.
More of
Sure, yeah,
like
right. Yeah, probably more focal rather than linear and longer segment. And sometimes it can be tough, right? Let me see. I don't fully remember what was the case here, but yeah, the deep veins are patent here. You can see nicely the internal cerebral vein, the straight sinus. Sometimes you can get arachnoid granulation right here at the junction. I think there was probably just a focal short segment clot anteriorly and posteriorly. So yeah, as a part of the checklist, what else is missing? What else have we haven't commented upon, which we need to see in the context of infection? And I think some people did mention it in the chat. So whenever you're reading your brain's CT head studies, you need to maybe have an internal checklist of lot of structures. So starting from inside out, right? And outside in, whatever approach you want. So um, let's see, what is this?
adenoids.
Adenoids, are they normal, abnormal?
Um, Enlarged, ma'am.
So yeah, they're enlarged, but are they normal
Yes,
or
ma'am.
are they abnormal? Yeah. So yeah, totally normal to have this sized adenoids in kids. We don't even mention in our reports. Um, what else is happening at skull base? So we are just windowing. Sometimes you can, in cases of acute trauma or stroke, one of my checklists is to look at this structure here. What is this at skull base? Do you know this fat, the triangle of fat? What is this triangle of fat? Lower down, especially here. The parapharyngeal fat, okay? And then, yes, somebody, let's see, parapharyngeal fat, yes. And what is this round structure here?
Yes, sir.
Uh, ICA.
Yeah, the ICA, right? So the internal carotid artery as it enters the skull base. So if I'm reading like any trauma or acute CT head studies, I usually, one of my checklist towards the skull base is I window this area and I look for any high density in the region of ICA. What can present as high density here in ICA?
Any atherosclerotic plaque or thrombus.
Hey, we are in pediatrics, okay? So you can forget atherosclerosis for a while. uh, but yes, something to do with maybe trauma and stroke. Yes, dissection, right? So atherosclerosis is obviously super rare, and maybe some genetic conditions. But in the acute setting, if you see high density here, and this is true for adults also, if you see high density here and you see some edematous changes upstream in the parenchyma, you're probably dealing with a dissection. So this is a good checklist to remember: high density of the IC at skull base. Anyways, I got a bit distracted. So here, what are we looking at? Do you see any abnormality on this slice?
No, ma'am. The mastoid are fine. There is no abnormality in the external auditory canal.
Okay. And what about
Maxillary sinus. There is no
sinuses? Yeah.
bulging.
Yeah. So maxillary sinuses, they have, how will you describe this?
There are fluid levels in the maxillary sinus
Hmm.
with
Okay.
mucus, uh,
Yeah.
and it
With
might also
it
involve.
might up. Yeah. Okay. So yeah, let us get this sorted first. So, it is extremely normal, extremely common to see a little bit of mucosal thickening and some opacification in the maxillary or paranasal sinuses, and also in the mastoids, right? Because especially mastoids in kids, like their eustachian tube functions are not developed. So it's totally fine to see a little bit of fluid. And if we see that, we just put it in the body of the report. We say that, oh, some mild degree of mastoid opacification seen, and just leave it at that. So if you were to see mastoid opacification, you need to just make sure that there is no external swelling, make sure that this, what is the structure here?
Sigmoid sinus.
Yeah, make sure that there is, the sigmoid sinus is fine, right? And it's just a little bit of incidental opacification. And we are not dealing with mastoiditis in any other example, not this one, of mastoid opacification. Similarly, if the moment you see paranasal sinus opacification, and look at the degree and the extent, sometimes it can be quite diffuse, and it can still be fine because the sinuses are not aerated, right? And it can look quite extensive. So we should not be calling sinusitis on CTs all the time. But this case is different. This patient is different because this patient has clearly presented with this empyema and some areas of edema, some areas of venous thrombosis. So here it is relevant, right? Here it is relevant. So, and there are some, definitely some little bit of air fluid level type of appearance and not just peripheral thickening. So this is relevant. But otherwise, in general, it's extremely common to see fluid opacification and thickening in the sinuses and mastoids. So please don't overcall sinusitis and mastoiditis. So that was another take home. So coming to closure of this case, and there are a few unanswered things. So here, when we read the scan, this child was 4 years old, and he had presented with fever, headache, lethargy, as I said. So our our differential was uh, early subdural empyema, and this can be hard on CT because you don't have the diffusion weighted sequence, right? But because of the history and because of the associated changes, that was the main main differential. And interestingly, this patient did not have an immediate MRI at all. He went straight to the OR, and because the clinical story was so obviously convincing, and the surgeons, they saw such a big collection, and there was so much mass effect. So he went straight to the OR, and you can see the MRI with some post-surgical changes. That collection was removed. It was drained. I will show you the diffusion also shortly. So I don't have that classic DWI image for this patient to show you that how extensive that empyema was, but I have some other examples I can show later. But you have this diffusion signal here, right? This is that empyema which they did not drain because it was on the medial surface. So just imagine if you were to do an MRI in the acute stage of that child immediately after CT, you would have seen a large crescent of DWI restriction all along this right convexity. And that was the reason it was causing so much mass effect and irritation of the brain, edema. And look at the ventricles. How are they now? The mass effect.
Mass effect has dissolved, ma'am.
Completely gone. Yeah. Right. So the scan was done like just 3 days interval between that CT and MRI. So he went to the OR, that empyema was completely drained. And this follow-up MRI was done to look for like what the baseline is after surgery. What are the residual pockets, how much antibiotics he will need, how long IV antibiotics will go on and so forth, right? So um yeah, coming back to that CT, there was just one more structure I wanted to show. Um, what is this thing here?
Superior ophthalmic vein, ma'am.
Yeah, right, exactly. So, you can devise a number of different checklists in your in your head and based on the clinical history. So let's say you're reading a scan for infection versus trauma. There are certain critical structures you should examine. So SOV, superior vein, can frequently get involved in patients who have complicated sinusitis. So let's say you're reading the scan for sinus infection. What are the important structures to look for? Superior ophthalmic vein. How are the extraocular muscles? So when you have opacification of the ethmoids, look for any thin sliver of abscess here. So look up cases of subperiosteal abscess in the orbit. So the intraorbital abscesses, sometimes they can be quite notorious, can be quite hard to discern because they are also quite thin. So that one of the take homes from this session is I'm probably not showing you too many ant minis of Dandy Walker and Chiari One and Chu, and obviously we have lots of those examples as well. I'm not showing you fast-paced cases of um, exam-related cases, but what I'm trying to impress upon you from this session is um, to obviously go slow, go methodical, um, and pay attention to relevant structures based on the history. So let's say devise your own checklist, let's say for infection and paranasal sinus, devise your own checklist. The other things which come to my mind in such a scenario are looking at these structures. What are these structures here on both sides?
Cavernous sinus.
Right. So cavernous sinuses, are they normal or not? Because occasionally you will get a requisition, rule out cavernous sinus thrombosis. So during those times, you need to be familiar with what can be the normal variations in the anatomy of cavernous sinus. Sometimes, do you see asymmetric enhancement? Are they bulgy? Are they like not well seen? So all those things, they matter. And again, the collection is not enhancing, that's not relevant, because even in cases of, you can have a clinically proven patient with meningitis, for example, and their brain scan can be normal. Or so meningitis is more of a clinical diagnosis with LP, right? And our role on imaging is to look for complications. So if you see enhancement or you don't see enhancement, that single thing alone doesn't dictate. And I think we got some really interesting uh, chat messages here, and some people did mention a few other conditions. Actually, in the interest of time, I'll just show you one case and then I will come back to some of those chat messages. So what's the exact time? We have 10 more minutes. Okay. Hmm, okay. I was going to find a particular case. Give me one moment. I hope my system doesn't crash. Then I will load too many studies. All right. So yeah, this is obviously a much florid example, and in the interest of time, I'll just tell you what's going on. But this is more like a companion case to what we saw. So this patient was initially scanned at 3-month age, and their clinical history was fussiness, oscillating mental status, focal seizure, rule out whatever's happening. And what they did was they acquired only post-contrast CT head, which is another mistake we sometimes do. We always need a non-contrast CT head to begin with, no matter what the indication is, right? So on this post-contrast, you see all these vessels, you see lots of big collections, and it is just impossible to tell on CT alone. And coming back, Julie, to your question, how do we tell whether it is effusion, hygroma, whether it's empyema, whether it's hemorrhage on CT? And the short answer is yes, it can be difficult on CT alone. That particular example was more obvious with like the fever, lethargy, and all those other things happening, and the disproportionate mass effect. So that was an empyema, and he went straight to the OR. But in cases like these, it is very hard to tell what's going on, and especially when you don't even have a non-contra CT head. So here, this particular case was mistakenly called as subdural effusion slash whatever meningitis or something. But I'll just show you the follow-up, what exactly was going on. This child had a long, long story. So this child, uh, I don't know whether we have a baseline CT. So after this CT was done, they went straight to MR, but I'll just show you an example of what I'm trying to say. So I think somebody had mentioned cortical vein sign and abusive head injury. So occasionally, if you see, this is not a super nice example. I have another case, but in the interest of time, I'm not able to load it up. But if you see more extensive linear high density along the cortical veins, and you can see like different named signs like tadpole signs. So this is an example of abusive head injury where there were extensive extra axial hemorrhages, and this initial CT was done with contrast, and so the extraaxial hemorrhages were completely missed. So that's the importance of obtaining a non-contrast CT in the initial stage. And this child, when the diffusion was done, they had lots of multifocal edema due to the abusive head injury, and the SWI sequence showed multiple areas of cortical venous injury and bleeds. So this is a big topic in itself. We can cover it the next time. But just to show you a compare and contrast case of empyema versus um, abusive head injury. So these are examples of, this is called the tadpole sign, where you have venous injury, bridging vein injury, and you have thrombosis of the cortical veins. And this is how it looks like on SWI sequence. The same thing, it can be important, really important to pick up on non-contrast CT head, which was not performed for this patient. So on a non-contrast CT head, the CT correlate is to look for this blotches and linear signs of high density along the convexity. So one of your checklists on non-contrast CT is to look for cortical venous injury. All right, I think we are towards the end. I can show you one more case, or I can answer some questions if you have any burning questions. Ashwini, thank you for your comment. Yes, I was definitely in the same boat. I did my radiology from KEM hospital, and in those times also we were like, oh, I want to see an interesting case. I want what's happening. We never want to like miss out on the rare things, right? But when you practice, when you become a consultant, or you are the probably the go-to person, or you hope to become the go-to person, what becomes important is, do you have the ability to call normal? Do you have the confidence to call, this does not require a venogram? No, this does not require a venogram or MR. So this is, yeah, this is my main message to you, is to look at as many imaging studies as you can in the context of clinical history. Um, for that matter, if you're just training your eyes to get used to how a normal T1 looks like, how how normal variations in all these white matter myelin look like, just open studies without the clinical history and look at them. Just give me one moment. Is it compulsory to do plain study for all before proceeding with contrast? So in terms of CT, yes, for sure. CT, we always start with non-contrast CT head. I can't think of any scenario where, even if the question is rule out venous sinus thrombosis, I do contrast. No, that's never the case. You can do both, but non-contrast CT is extremely important. The other take homes, again, I will emphasize, do not use the word clinical correlation. Do not call sinusitis and mastoiditis based on CT alone unless you see any adjacent complications like abscesses or venous sinus thrombosis, because fluid in the mastoid sinus and paranasal sinus is extremely common. Try to make your own checklist, you know. One case which I really wanted to show was actually I wanted to show some MR studies, but I think we might. I- what do you think, Rishabh and Joy? We'll probably have to do a different session, right? For MR, I think because it will, this will need a minimum of another 15-20 minutes to dissect whether this white matter is normally myelinated or not. Let's call it a day. I think today's CT session was good enough, and maybe in the next session we will focus on differentiating HIE or um, white matter injury from what normal newborn brain looks like. All right.
Hello, good
So no,
evening.
I think yeah, I think
This is
I'll
Dr. Antriksha this side. I'm one of the co-hosts.
yeah.
I would like to thank you, ma'am, for an informative session, and we can definitely arrange another session for the topics if you want.
Right. Yeah, let's do that. Yeah. I
We'll
don't
do
I
that.
don't think I will not start MRI because this is way too late. Yeah. But yeah, if there are any other burning questions, Joey, did I answer your question about infection? You had a question about,
Yes, ma'am. Thank you so much.
okay. No, you guys did well. You know, you did great. So both of you. So it takes a lot of courage to speak in front of such a big audience. I don't think I would have been able to do it when I was a resident. So thank you for doing it. And yeah, um, I can just type my email in the chat because I have to go to. So if there are any other burning questions, you can email me. And in the meanwhile, just keep looking at imaging studies, not with the intent of, hey, did I miss anything, any rare disease or anything cool, you know, just look at with the intent of, you know, making yourself comfortable with what normal is.
Thank you so much,
All
ma'am.
right. Okay, awesome.
Looking for the MRI.
Yes, ma'am.
Looking.
We had like the normal cases were more important. Like pediatric cases we come across so rarely. So thank you so much for doing the normal cases as well.
Yeah, absolutely. Okay, we'll do that next. Thank you. Bye.
Thank you, ma'am.
Thank you so much, Dr. Anvita, for a lovely
Thank
session.
you.